Illness anxiety disorder versus somatic symptom disorder. Illness has the ability to initiate fear in anyone. Whether you're wondering if that cough is an oncoming cold or that muscle weakness means a few days off work. With the recent health scare surrounding the COVID-19 pandemic these past few years, fear about one's health seems to be even more common. However, for some people, the fear of illness can be so overwhelming that it develops into full-blown anxiety and impacts their daily tasks, social interactions, and occupations. Illness anxiety disorder and somatic symptom disorder are two such mental health conditions published in the DSM-5 and are both related to the fear of falling ill. The DSM-5 introduced these two mental disorders, derived from hypochondriasis, which was previously described in the DSM-4. This revision was done not only to increase the accuracy of diagnosing patients with health anxiety, but also to limit the negative connotation that the term seemed to have received. Illness anxiety disorder and somatic symptom disorder are relatively similar in their cognitive presentations of debilitating anxiety related to illness. However, their somatic symptoms are what distinguish between the two disorders. This video will take a brief look into these two health anxiety disorders, describing their characteristics, causes, and treatments. Illness anxiety disorder. Picture someone who is so enthralled with their health that they obsessively check every single mark on their body, researching everything that is known about a certain disease to determine if they are ill, or someone that only speaks about their health concerns when spending time with others, that their relationships eventually are affected. These are examples of the life of someone with illness anxiety disorder, or IAD. According to the DSM-5, a patient who is diagnosed with IAD is preoccupied with acquiring or believes they already have a life-threatening disease. This preoccupation will result in them developing a fear of anything remotely related to the disease in question, and prompts them to spend an obsessive amount of time researching and thinking about the disease or diseases they believe are related to them. IAD has an equal prevalence between women and men and usually develops in early adulthood. There are two types of IAD: care avoidant and care seeking. Care avoidant. In the care avoidant type, patients are less likely to seek out medical care due to the intense anxiety it brings, and the belief that by doing so, their fears of having a life-threatening illness will be confirmed. Care seeking. In contrast, a patient who is described as a care-seeking type will make regular doctor appointments and is often seen at the doctor's office because they want to receive confirmation that they do not have an illness. This will usually result in them asking for medical examinations to be conducted, such as blood tests and scans. However, even if the results come back all clear, this usually does very little to ease the patient's anxiety about their health and frequently causes them to visit other doctors for more opinions because they're not reassured. Diagnostic criteria. Using the DSM-5's diagnostic criteria, we can get a better idea of the symptoms of someone with IAD. A. Obsession with health. The individual truly believes that they are either at risk of obtaining an illness or they already have an illness. The particular disease may be dominant in their family, like diabetes or cancer, a completely unrelated disease, or even a disease that has lately been rampant in their environment, like COVID-19. B. Somatic symptoms do not have to be present. The presence of any somatic symptom is not required for the diagnosis of IAD, as it is not the symptom, but the actual illness that causes anxiety in the patient. Any presence of a symptom will cause the patient to hyperfixate on the possible outcome rather than on the symptom itself. This is what distinguishes IAD from somatic symptom disorder, because patients with IAD are more focused on the possible illness they think they have or will obtain rather than any related symptoms. The symptoms are merely a further indicator to the patient that the illness is present. C. Extreme anxiety about personal health. The individual's preoccupation with their own personal health prompts intense fear and even anxiety within them, which has negative impacts on their daily functioning, social interactions, and occupations. D. Unreasonable behaviors related to personal health. An individual will either spend an exceptional amount of time investigating their health and making doctor appointments, or they will do everything in their power to avoid anything related to their health. This diagnostic criterion is used to determine which type of IAD the individual has. E. Duration of symptoms. They have had a fixation with acquiring an illness for more than 6 months. Their fixation does not have to be on one specific illness within this 6-month period, but it can change. Etiology. It is still widely unknown what the exact etiology of IAD is. However, research has revealed a few theories. Number 1. Trauma. The majority of people with IAD have experienced a traumatic event in their past that was related to either them being seriously ill or someone close to them having a life-threatening illness. This had such a massive impact on their mental health that they developed IAD. Number 2. Anxiety disorders. People with other anxiety disorders, like generalized anxiety disorder or obsessive-compulsive disorder, are also more susceptible to developing IAD. Number 3. Upbringing. Someone who is brought up in a health-anxious environment is at higher risk of developing IAD. Number 4. Research related to health. Another cause is spending an extreme amount of time researching anything related to health, especially if the topic in question is a dominant illness within their family. Number 5. Sensitivity to body sensations. People who are already very aware and even uncomfortable with normal body sensations may also eventually develop IAD by frequently worrying that any changes indicate an illness. Somatic symptom disorder. Imagine being so hyper-aware of your bodily sensations such as breathing, vision, hearing, etc., that any deviance from what seems normal prompts intense anxiety that you may be experiencing a life-threatening disease. For example, a slight change in breathing might make you believe you are having heart palpitations and experiencing a heart attack. Minimal visual blurriness may without a doubt mean you are having a stroke, or a change in urine color may indicate a chronic illness like diabetes. This is just an indication of what living with somatic symptom disorder, or SSD, is like. The major difference between SSD and IAD is that patients with SSD will have the presence of either one or more physical symptoms that encourages their anxiety surrounding their health. The exaggerated response to these symptoms is what classifies the patient as having SSD. For example, someone with SSD may fear that pain indicates they have a life-threatening illness like cancer, whereas someone without SSD may not give too much thought to the pain unless it gets worse. It has been proven that these patients are not feigning their symptoms. However, there is usually no medical condition that can be identified. Even with multiple medical tests proving that the patient is not suffering from an illness, they will still not be reassured. Much like patients with IAD, and their health anxiety will continue to impact their life. However, when a patient with SSD does actually have a medical condition, their overall response to the symptoms of illness will be overemphasized. According to research, SSD is more prevalent in women and will often present itself before the age of 30. Diagnostic criteria. Let's have a look at the DSM-5's diagnostic criteria for someone with SSD. A. Presence of a somatic symptom. At least one reoccurring physical symptom that has impacted the individual's life in a negative way. This is the most definitive diagnostic criterion, since there has to be the presence of one somatic symptom or more in order to be diagnosed with SSD. These symptoms range from mild to severe, with pain being the most common symptom reported, followed by fatigue, muscle weakness, and shortness of breath. B. Disproportionate response to the somatic symptom. The individual will have exaggerated thoughts, emotions, and behaviors in response to the symptoms, and this may result in anxiety about a possible associated medical condition. The person's anxiety is so overwhelming and is based on worries that the presence of these symptoms is proof of a serious underlying medical condition. These patients also spend an exorbitant amount of time researching and visiting doctors to investigate the somatic symptoms. This has the ability to negatively impact their daily life and relationships. Depending on how severe the patient's response is and how much it impacts their life will determine the severity of their SSD. C. Duration of symptoms. The person must be symptomatic for more than 6 months. However, the actual symptom can change during this time period. Etiology. Just like with IAD, it is still widely unknown what may cause SSD. However, here are some possible theories. Number 1. Sensitivity. Individuals who are more sensitive to bodily sensations, especially pain, and respond more emotionally to these sensations have a greater chance of developing SSD, because they are naturally more aware of normal body sensations and therefore determine any anomaly much quicker. 2. Genetic. Any individual who has a predisposition to a decreased pain threshold will be more sensitive to pain and experience a higher amount of somatic symptoms. Number 3. Learned behavior. Another theory is that some individuals experience these symptoms as a subconscious effort to receive attention, especially if they have recently healed from an illness. For example, Someone who has recovered from a myocardial infarction may still experience the somatic symptoms indicative of the condition because they are subconsciously seeking the previous benefits and attention they received when the actual attack occurred. Again, patients with SSD are not lying about their symptoms. Number 4. Negative personality. Naturally, someone with a negative outlook on life will immediately associate certain physical symptoms with them having a life-threatening illness. Number 5. Trauma. Individuals who are brought up in traumatic or abusive environments, physically or sexually, are more likely to develop SSD. However, trauma is not the main cause of this disorder. Treatment of illness anxiety disorder and somatic symptom disorder. Treatment for IAD and SSD are very similar. The most important thing is for the individual's healthcare provider to eliminate any medical condition by performing the relevant examinations, and then to partner with a mental health professional. It is vital for the patient to have a healthcare provider that they trust and who supports them so a relationship of assurance is established, and they can also be protected from unnecessary medical examinations. Together, the mental health professional and healthcare provider will usually recommend psychotherapy and possibly medication. Psychotherapy. Once the threat of a medical condition has been removed and the patient is being diagnosed with either IAD or SSD, they will usually be referred to cognitive behavioral therapy, or CBT, in order to learn how to manage their anxieties, function better with daily tasks, improve their relationships, and return to their occupation. Medication. Antidepressants and anti-anxiety medications, usually selective serotonin reuptake inhibitors, or SSRIs, are often added to the treatment regime, especially when the patient's anxiety is severe and they're also experiencing depression. These medications may be exceptionally helpful in alleviating physical symptoms, including pain. Supporting someone with IAD or SSD. So far, this video has shown how debilitating the life of someone with IAD or SSD can be. However, it is just as challenging for those who live with them. If you know someone with one of these mental health conditions, here are some suggestions on how to best support them. Number 1. Let them talk. Give them the space to discuss their fears without any judgment, and assure them you understand how they're battling. However, be sure not to encourage their obsessions by remaining neutral in your answers. Number 2. Support them. Rather than encouraging their obsessive behavior, encourage them to remain diligent in their treatment regime. It is even helpful to attend some psychotherapy sessions with them so you can better educate yourself on how to help them. Number 3. Be patient with them. Possibly the most helpful way you can support them is by being patient. Any form of anxiety is very difficult to live with, and they're not choosing to feel this way. They need someone to be empathetic with them, even if it means finding yourself a therapist to help you cope. In conclusion, IAD and SSD are two categories of health anxiety that can make a diagnosed person's life extremely troubling. Therefore, they require people in their life, from their closest loved ones to mental health care providers, who can assist them to find some kind of normal to their daily living.